Today. Okay, so our next session is a video session. And our first video is on basic non-invasive vascular testing by Dr. Gary Gibbons, who needs no introduction as an expert in vascular care and the care of the patient with a diabetic foot. Dr. Gibbons.
Thank you very much. This is not going to be a video, but it'll be rapid fire. So I'm going to talk about the basic non-invasive vascular test. And I think the best way to do this is just to carry on from the previous session when people were talking about the diabetic. And I don't know how you get them already. Maybe it's this one. Here we go. So clearly what you've been hearing is unrecognized, untreated, and or inappropriately treated ischemia increases the risk for major amputation. And clearly for any discussion of diabetic wound healing, we have to discuss the circulation, both the clinical and taking a good history, beginning with the physical exam. And why is that important? Peripheral vascular disease, this is our own series of 101 documented episodes of pedal osteomyelitis, and what we found is some component of peripheral arterial disease was present in almost 60%, and this was similar to the data of Roger Pecoraro and Gail Reiber years ago. So the ideal non-invasive vascular test, non-invasive, technically easy, fast, accurate, reliable, and reproducible, and inexpensive and reimbursable. So get ready for that one, because as we're seeing population health and ACOs, all of this is going to be wrapped up into your evaluation. We've already talked a lot about this, so I won't say a great deal. Ankle brachial index, for those in the audience, non-vascular, you take the blood pressure in both arms. You then take the pressure in the ankles. We have our nurses trained and certified that they do it over the PT and the DP, and high sensitivity and specificity, except when you get to diabetics. The red is what so your ankle pressure should be equal to your arm pressure, i.e. should be 1 or slightly greater than 1. So here's the problem with diabetics: medial calcinosis, so that calcium deposits within the arterial wall, and this leads to almost like lead pipes. So it's very common. We actually, when we reviewed our non-invasive tests at the Deaconess many years ago, we had to throw them out because over a third of the patients had falsely high pressures. And really, when you get that arm cuff up greater than 230 millimeters of mercury, it becomes a little bit too painful. So falsely negative, again, falsely high pressures, a low ABI is significant that something is going on. So again, have to be done with a word of caution in diabetics. This is what we do, is toe pressures, and previous speakers have talked about that. And again, 70 to 110, it should be a little bit less than the systolic pressure. 40 or less is the wound healing is compromised, and 30 or less, we have the diagnosis that something has to be done as an intervention. So again, can you use those to predict healing? And I think what you've heard now is that these are one tool to decide, is ischemia, does it correspond to your clinical evaluation, and does that patient need to be further investigated? Pulse volume recorders is a qualitative study. Calcified vessels do not limit their utility, and what you're looking at here is the volume of blood going through a segment of the leg at any one particular time in the cardiac cycle. And then we talked, Dr. Legurfo talked about the microcircular dysfunction and all of this. This is where we use a TCOM. It's the newer instruments have become fairly simple. There's less error in doing them. You've seen this study now. So these are kind of like the basic tests that one can do. But what I really want to get back to, and what we've done in our clinic, is that we have trained and certified all of our nurses to really do a good pulse exam, a good history. That's where you really can learn a lot about this. So you can see the neuropathy, you can see autonomic neuropathy, you can feel for the pulsars, and then we use a handheld Doppler and evaluate for the quality, triphasic, biphasic, monophasic, and then do Doppler waveform analysis as well. Thing that I just wanted to say with all of this, these tests are only complementary to good clinical judgment. So again, when you're looking at the patient, all of these things, they're only as good and they're complementary to your clinical judgment evaluating that patient. And that we were talking earlier, and I wanted to just make a comment about the non-vascular surgeons in doing some of these interventions, because it's the entire diabetic patient. You can do a great revascularization, great pedal artery bypass, and if you let the patient walk on a first metatarsal ulcer, you don't offload that patient, your bypass is only as good as the rest of the care that goes with that patient. And the same as you can have a very ischemic limb, and then when you reperfuse that limb, that's when you wake the bacteria up, and you got to be prepared to do something about it right away. So these are all the things that you need for healing chemicals, non-cycling matrix. The most important thing is debridement of acute infection. Someone said, my previous quote, never let the sun set on a diabetic limb or life-threatening infection. It doesn't matter what the circulation is. So we're asked this all the time, control infection. That means debridement, debridement, debridement. No wound is the same. That's the other important thing. So sharp debridement, and then you get your tests immediately within the next 24 hours. If you're doubtful about whether ischemia is complicating that wound, we'll get the basic non-invasive tests. We won't get a lot of the advanced tests. You have to remember, if the patient's in the hospital, everything that you do goes on the DRG bill. So whatever you can do, you want to try to keep it as an outpatient on the outpatient side. So again, neuropathy, vascular disease, and an abnormal response to infection. So what may be an ankle brachial ratio of 0.9 and pretty good circulation in one patient may represent significant ischemia in another diabetic patient. No wound is the same, no diabetic. As Dr. Legurfo said, foot biology is the same. So you can't look at this as clearly just a management of large vessel, small vessel, occlusive disease. It's the entire diabetic patient, the wound, the medications, the microenvironment of that wound. All of these things are important in what needs to be done and the part that the circulation bears in all of that. So vascular diagnosis and intervention, again, keep it with the simple tests early on. They're one part of a multidisciplinary wound healing and limb salvage program. If you have a team approach to this, our job as vascular surgeons is to provide an environment where our podiatric colleagues can go in and do some type of reconstruction afterwards. And what we showed at the Deaconess is we reduced every level of amputation and really got into more reconstructive foot procedures. So intensive, ongoing, preventative, medical, surgical follow-up. I do think there's a role for these tests in following diabetic patients along, as well as a yearly podiatric evaluation. But again, some of the story may be down this. This is not just about managing vascular occlusive disease. Vascular abnormalities begin early and not infrequently herald the diagnosis of diabetes in patients who were previously undiagnosed. You heard some cases today where people will present and they're found to have diabetes based on the treatment of the wound and the ischemia with it. Vascular atherogenic inflammatory rheology abnormalities increase with the duration of diabetes and poor blood sugar control. You saw evidence of that today. So diabetes is a vascular disease. It is a tremendous inflammatory vascular disease affecting every artery in the body. So these tests are complementary, but they really don't give you the real full armamentarium of what's going on in that wound, as Dr. Lugurfo described as the biology of that wound or the wound microenvironment. The diagnosis can be difficult, a lot of variables, and the overall result is early and accelerated atherosclerosis, and the realization that because it's such an inflammatory process, you can see sudden atherosclerotic plaque destabilization that occurs in all of these patients. So they have a lot of rheology abnormalities, so the relationship between clotting and lysis, all of these things are affected. So I hope what I've given you is some of the simple tests. I think the most important thing is if you're taking care of a sizable volume of these patients, you really want to get used to your fingertips examining the patients and also just using a handheld Doppler. You really, it's probably your best friend. We don't use the sophisticated tests if we don't need to. We will, if with someone with real limb-threatening ischemia, we will do, if we think they're ischemic, we'll go on and go right to arteriography. Thank you.